Hello and welcome to today's edition of We Own It Live. Today we will be talking about the crisis in our NHS and how you can be a part of the fight to rescue it this general election. Hi everyone, and thank you so much for joining us this week for another edition of We Own It Live. As some of you will know, we try and hold this as much as we can to discuss issues that we think concern people across the country, people who use our public services, from our buses to our railway to our NHS. And today we will be talking specifically about the NHS. This session comes just a week in advance of the launch of our new NHS campaign. The campaign is called Pledge for the NHS. In this campaign, we want to mobilize tens of thousands of people across the country, like yourself, to demand that your local election, general election candidates commit to more funding for the NHS, an end to NHS privatisation, and the reinstatement of the Secretary of State's duty to provide healthcare to everyone. The campaign is launching on Thursday next week, so there's not very much more that I could give you right now on the campaign. But it's really important for you to know, for everyone to know, that this is our big opportunity. Our NHS has just lived through 14 years of significant underfunding, outsourcing, understaffing. I don't think it's very much of an exaggeration to say that the NHS might not survive another 5 years of the same. So it's really important that we come together. Individually, we can be ignored, but together we can have a big impact. So this campaign is our opportunity to come together and demand change on behalf of our NHS. Today's session also comes at an important time as the BMJ is a medical journal, has put together a commission on the future of the NHS, and they have recently come out with the first report in a series of reports that they hope to be putting forward. And we think obviously this is an important report because it brings together a good number of NHS experts. And I wanted to kind of start by highlighting some of what that report found. If we could put up, so the Guardian covered the story yesterday under the headline, "Next Government Should Declare a National Health Service Emergency," and they're demanding that the NHS should be relaunched under the founding principles. Some of the recommendations of the report are as follows. If we would put up those recommendations, so they're asking that there should be a clear statement of commitment to the NHS and its founding principles, and engaging all parts of society in a renewed vision and plan for health, care, and well-being, and that will generate and buy-in and the momentum to implement necessary reforms. And I want to jump to the last one, providing some additional funding to support early improvements and commissioning, a review of future sustainability similar to the 2021 wellness review. We think this is an important development. Obviously, it has its limits, as we are going to discuss in a moment. But it's very, very important to see that voices from right across the health policy spectrum are demanding that more funding be put on the table. And that's why we are also demanding that more funding be put on the table. We cannot fix the crisis in our NHS without more funding. And in order to have this discussion, we're speaking today to Dr. John Lister. If John could be brought onto the screen with me. Thank you so much, John, for joining us today. I'll do a bit of an introduction of John. John is a journalist. He is the co-editor of thelowdown.org.uk. If somebody could put that on the screen at some point throughout this. It's in some ways my primary resource for finding out news about the NHS, and it's very, very incisive analysis about what's actually happening beyond the narrative that politicians like to put forward. The website is lowdown.info, lowdownNHS.info, and it's going to be on the screen soon. He's also an academic, of course, and he's the co-author of two books, one book and an update to that book from 2015, rather. The book NHS for Sale, Lies, Myths, and Deceptions. Um, if you do not have this book, I would recommend buying it. It's an important book, and it's recently been updated. If you look behind John right now, you'll see NHS Under Siege. That was published in 2022. It's an update to this book. Please do go and grab those books. And if you want to familiarize yourself with how the NHS has been dismantled over the last number of years, these books are your guide for that. Thank you so much, John, for joining us.
Welcome. Yes, good to talk.
So what is your initial reaction, I guess, to the BMJ Commission's recommendations?
Well, I think it's important. One of the ones you haven't picked out is in the body of the text. It recommends that the government, in post after the election, should declare a national health and care emergency, calling on all parts of society to get involved in putting it right. I think that's important because it does seem that the Labour opposition, which appears to be the most likely government in waiting from the next election, seem to spend most of their time denying that they're going to increase any taxes or raise any additional funding from the rich or from big business or from anywhere, and therefore effectively denying there's going to be any extra money. And I think that without more money, as you said, then the prospect of actually putting the NHS back on its feet after 14 years of underfunding is pretty almost negligible. I mean, so many services are right on the point of collapse. So I think an emergency is a correct statement. Certainly, if we had, for example, a repetition or an attempted repetition of when Tony Blair came in 1997, committed to 3 years of the Tory spending limits, which they stuck to until 2000. I think the NHS would fall over here because the Tory spending limits are completely inadequate for the NHS going forward towards 2030. So we definitely need emergency measures. And declaring an emergency would give a basis on which you could effectively roll back on some of the, I think, completely misguided promises. The most recent, I think, was not to increase taxes on the super rich. There's all this talk about the Tories potentially cutting into inheritance tax in the run-up to the next election, which would leave, again, a Labour government potentially pinned down by the lack of that as an option to go forward. So I really do think that's a very useful element of what the BMJ Commission's proposing. I am slightly worried, however, that their talk about funding comes right at the end, providing some additional funding to support early improvements. I think it's a good idea to commission a review. The one list review of 2002, they got the date completely wrong. Don't know how they've said it's a 2021 one list review, but one list review. It was commissioned by Gordon Brown from the Treasury, and it was developed by the new Labour government as the argument as to why they were justified in the decade of really substantial increases in NHS funding that followed on Tony Blair's announcement in 2000. So they basically announced the policy, set up the inquiry to justify the policy, and then a year later or 2 years later, they came up with that evidence that showed the extent to which the NHS had been underfunded compared to other governments in Europe, other comparable governments over the preceding period. I think that is a useful thing to do again, and there's plenty of information to show that the extent of that funding gap. But I do think in the meantime, a much bigger focus needs to be on how much money we need to start putting things right. And, the SOS NHS campaign, partly at my urging, has actually adopted a call for a 20 billion injection of cash up front to kickstart the process of actually rebuilding and restoring our NHS after a long period of austerity. And I think that's pretty much a minimum without which we can't really get the process underway.
Absolutely. Couldn't agree more, John. And the keen-eyed among you will see that we've had a change of chair.
We've just had
a couple of technical difficulties. And if there is a bit of a delay to my audio, I hope you'll forgive me. My setup was not designed for hosting this evening. But thank you, John, for a really insightful answer. One of the places where we come into funding is where lots of the money is leaking out to. And in my experience, that partly reflects what's happening with outsourcing and privatisation in the NHS. So I wondered if you would give us your thoughts on what the core problem with NHS outsourcing and privatisation is. Why is that such a key issue within the health service?
Well, there's kind of an immediate term and a longer term problem. If you divert money from the NHS budget into buying services in from outside external providers, you effectively start to build up a parallel service or a bolt-on service from outside of the NHS. And that works against any prospect of trying to genuinely integrate and make the whole service work more efficiently together. You wind up with services that are provided by companies that are accountable not to the NHS but to their shareholders, and you wind up with something that's much less able to actually go forward. And of course, in the context of waiting lists and trying to actually get the private sector to help deal with waiting lists, the private sector only deals with the most minor elective cases. So you take them out of the NHS, but you also then have to take the staff to go with them, because the private sector is not resourced to do a great deal of additional work above its normal caseload. So they wind up poaching staff. All the staff are trained by the NHS, trained by the public sector here. The private sector doesn't train any staff at all. So they've been effectively looking for NHS nurses and doctors off the wards that we're trying to keep open. And effectively, it works out a zero-sum game. The figures on hip operations, for example, show that actually overall hip operations have simply been transferred from NHS, delivered in NHS hospitals, to being delivered more and more in private sector hospitals funded by the NHS. But the actual total of hip operations hasn't gone up. So the private sector's pocketed the money, but the NHS hasn't gained any additional capacity at all. So I think that this is not a way forward at all. And in the longer term, I think the reality is, even though we're obviously against the profiteering element of it that is clearly there in the private sector's eagerness to get more NHS contracts, even if you set that one aside, I think the whole idea of building up a parallel service rather than focusing on developing NHS expertise and NHS capacity to treat the caseload that we have in this country, I think is a completely wrong way to set about it. And if the Labour is going to focus on that as their main solution to anything, they're going to find themselves way adrift of what they actually need in order to get the NHS back on its feet.
Absolutely. And I'm delighted that we've now got Johnbosco back. So I'm hoping we'll be able to have him provide a much more insightful commentary on your fantastic answer there, John. Johnbosco, I'll hand to you now to give us some more thoughts.
Thank you so much, Matthew, for jumping into the breach on my disappearance. Sorry, this doesn't happen often. My light just went off for some reason. But I just caught up from your response there. You're talking about what is at the heart of what's wrong with privatization. One of the figures that struck me recently, we discussed this in one of the earlier YouTube lives that we did of an analysis by the Sunday Times that essentially the title was, "You can pay for private healthcare, but can you trust private healthcare?" And the catalog in this article, a list of ways that private healthcare companies put profit before people in terms of things like unnecessary tests. And a doctor, for example, recommending a test to a patient who they suggested they might have cancer simply because this doctor has shares in a company that provides cancer checks. Could you speak a little bit more, if you like, to that question of the kind of framework of incentives that you touched on toward the end of your remarks? But I think perhaps even more importantly, as part of that same report, they also said that 550 people every single month are being transferred from private hospitals to NHS A&Es. And obviously, this is having the way that the Sunday Times put it is that they're kind of dumping these people at the NHS hospitals. Why is it that politicians see this reality yet allow for the narrative to ferment that the private sector can help us deal with whatever is ailing the NHS at the moment?
Well, I'm not sure that how much they do really believe that. I mean, the big thing, of course, is the NHS is the only provider of emergency services and of more complex care in the country. The private sector doesn't do that. Private sector hospitals average between 40 and 50 beds. So they're not geared up to taking any just think of that compared to the very smallest of the NHS general hospitals, which are 400 or 500 beds. Even I think the very smallest is just below 400. But I mean, it's a completely different type of animal from a private hospital. So if you're geared up only to deliver elective services to people who basically are otherwise fit, because the private insurance model aimed at people of working age, who are basically ideally really healthy people, so they keep paying premiums but never have anything wrong with them, never actually make a claim. That's the way the private sector makes its money, and the hospitals were geared to that market. Now there's no way that it's going to start building, there's no money in building more general hospitals in the private sector, because they'd have to charge so much more than the NHS to be able to make that vaguely profitable. So that's never going to happen. So as you say, if something goes wrong, an emergency effectively happens on an operating table in a private hospital, they've got no choice but to send people to the NHS for treatment. They can't deal with it there. They don't have intensive care units in almost all of the private hospitals, because they're not dealing with that type of operation. So the idea that, for example, the idea that people going private is going to make any difference at all to the numbers on trolleys waiting for admission, and it's none whatsoever. They're there because the NHS is the only place they can get the treatment, and the NHS is bunged up because the hospitals can't discharge patients for lack of social care at the other end. But the private sector is won't contribute anything to that. And you no way can buy your way out of it. If you've got a fat wallet in your pocket as you're knocked down in the street, or you've got private insurance, it's no good to you, because you're going to wind up taking it by NHS ambulance to an NHS hospital, and that's your only option. So this is why it's important to argue actually the NHS is actually the only service that covers absolutely everybody. The rich depend upon it just as much as the poor. Okay, you might occasionally get a royal wheeled into a private hospital with something that might otherwise have gone to an NHS hospital, but that service is not available to anybody else. It's not like you can actually say that's a fully parallel service. And I think the other side you mentioned about unnecessary tests and so on, you can really see this in the United States, where of course the private sector is in control, and you've got the total amount of money wasted in US healthcare is around a third of the budget of $3 trillion a year. Is actually wasted. This is official reports have calculated this, and one of the central factors is unnecessary treatment. It's unnecessary treatment on the one hand, where people get sent for expensive tests and X-rays and MRIs and so on that they don't necessarily need. But there's also undertreatment, which means that all kinds of people who should be accessing care can't afford it and don't, and wind up coming in with much more complicated diseases later on and problems later on, and aren't covered by cover. So it works both ways round. The private sector is incapable of delivering a comprehensive healthcare system, and they don't anywhere in the world provide a comprehensive healthcare system for the whole of the population. They provide, and in the US, you can see that worked out in full detail. So I think it's really important to remember that the limits of what the private sector is prepared even to offer to do, let alone claim to actually deliver on a day-to-day basis.
Absolutely. I mean, one way to think about it is, I said this to a Metro journalist recently, and because I'm very proud of it, I'm going to say it again, that we had the American system in the UK, or something approximating the American system in the UK, and just to get away from it, we created the NHS. We created this revolutionary system that has saved so many lives and saved so much money over the last number of decades. We cannot allow ourselves to get back there. And kind of speaking a little bit more to the point you made earlier, some months ago, we launched what we called the Only the NHS campaign. And it was essentially our goal in that campaign was and continues to be to make sure people understand what is at stake if we allow politicians to kind of shove our NHS to the side under the guise of the private sector helping us cut waiting lists. Only the NHS takes care of everybody. The private sector only deals with simple, straightforward cases that, as you say, people that are otherwise well, that just need certain operations, that they could just do once and that's it. Only the NHS trains doctors and nurses in any significant amount that we would actually benefit from across the whole of the NHS. And only the NHS has A&Es. So if you have an emergency today, you will not be seen in the private hospital. And the way that I like to think about it, the first day I heard about it was, if you were in a private hospital getting an operation and a microwave falls on your head inside the private hospital, they will take you, put you in an ambulance and take you to an NHS hospital. That's how
worse than that. My dad was in a private hospital unwisely decided to have a knee operation at short notice, and they didn't do proper blood tests before he was admitted. And it turned out, since the previous operation he'd developed a rare form of haemophilia. It meant that the wound wouldn't, the joint scar wouldn't heal, and every time he went to stand on his leg, it started bleeding again. And they couldn't discharge him. And he was actually in a Bupa hospital for just over 3 weeks, instead of the couple of days that would normally be the case. And every day, a consultant was put his head around the corner and say, "Are you still there, Mr. Lister? You know this is the most expensive hotel in Cardiff, don't you?" And in the end, they just gave up on him, put him in an ambulance and sent him to the University Hospital of Wales in Cardiff, where it took a multidisciplinary team to actually work on it and get him walking. Well, he hardly walked again after that. But it's a classic example. The private sector cannot deal with these things. They don't have multidisciplinary teams. They don't have teams of doctors on staff. They basically have people come in on sessions to do work and go away again. And anybody who really thinks they're going to get top-class treatment in these hospitals is kidding themselves, because it might feel very comfortable. You probably get a nicer meal served up, and you probably, may well be in a single room. I tell you what, if you're in a single room for 3 weeks, as my dad was, on your own, going stir crazy, wondering if you're going to have to sell something in order to actually pay the bills, then that's far from the most luxurious way to be treated.
I do want to come back to the question of, we win our campaign, we get more money into the NHS. What would John Lister do with that money? I would come to that question soon, but I do want to talk a little bit about the question of people paying for care, right? Obviously, we were able to dodge that bullet by creating the NHS, and the idea of medical debt is not something that's common in the UK. Obviously, it's beginning to become a factor with people going to take loans in order to get care in the private sector because of our huge waiting lists. But in the US, 500,000 households every single year, according to one analysis, go bankrupt as a result of medical debt. And you touched earlier on the question of people not being able to get care because, number one, they don't want to pay for the ambulance. They have a problem. The first thing they think about is, how much is it going to cost me? So they don't go see the doctor. And people don't think about it a lot here in the UK, right? Because obviously, if you look into the price of health insurance at the moment, it almost does not look very big, because it seems like, well, it doesn't. If you make a lot of money, it doesn't look very much. But people should know that from the recent research I carried out for something that we're working on, you would be paying upwards of £1,500 if you're a family of 3 or 4 every single month for health insurance, if we did not have the NHS. And I wonder what you have to say about why people don't realize this, like this is what they would be standing to deal with if we did not have the NHS, and if they don't join the fight to save the NHS.
Well, you see, I don't think we'd actually wind up with the American system as such, because that system is rooted in a very strange political history of the United States, where there was no actual representation of the labour movement, and then the unions got bought in on the idea of special health cover for their own members, and each union regards it as a bit of a blow if somebody gets more general rights established. So it's a very strange topsy-turvy world in terms of the politics there. And I don't think there's any government in the world, in Britain, that you can conceive of that will actually have the nerve to come in and try to actually go from what we've got now to what we got there. What we could well wind up with is a situation where they continue to focus on building up the private provision, and just leaving the NHS as a skeleton service, which gives less and less support to those who actually need it most. I think that's not more like the Irish system or the some of the European systems, and so. I mean, I think we need to be careful, because we're not going to wind up with everybody. You can't buy most of the services that people most often need. So it doesn't actually, an insurance option isn't there, because you can't actually, there's no way the private sector is going to be persuaded to build a whole series of general hospitals or take over NHS hospitals, which can't even balance the books within the NHS, let alone deliver a surplus to shareholders. And you just wind up with an impossible scenario there, which would be politically indefensible, even for the most right-wing government you can imagine. But the bigger problem is you just let our current model decay to the point that certain services collapse in key areas. People just aren't able to get the care they want, and you've lost what was a fantastic heritage and a fantastic historical gain. Ours is the most modern system of the lot, because it superseded the market. In 1948, you had a system that no longer delivered on the basis of profit or on the basis of ability to pay, but on the basis of delivering services according to need and free at the point of use, funded through general taxation and not through the individual's contribution in any way whatsoever. It's not an insurance system. It's a health service with a right. That is the base. That is its basis, and that is historically the most advanced system there is. Nobody's got any further than that. So anything you do now to tinker with that is dragging it backwards to old models that we had before. If you go back to more and more reliance on insurance, you're going back to the 1930s and previous systems that we had in this country that would, during the war, people were fighting to get out of that. They saw the emergency medicine system in the war, and they realized that systems could be much better than they were. And the NHS was a result of that. Anything that tries to, despite what they may say about modernisation, anything that tinkers with that model is actually dragging us back to things that we rejected long ago.
So what you're telling me, John, is that politicians like to talk about innovation, but what they forget is that the NHS is the innovation itself.
Yes, exactly. Yes.
Absolutely. So I do want to come back to that question of what would John Lister do with £39 billion more per year in
39.
Funding?
39. Well, that's you're not going to get 30. 20 billion is quite an ambitious figure, and I think if we could get that as a down payment and a commitment to increase over the next decade in the way that Labour previously, New Labour put 10 billions extra year over 10 years. Then I think that's a starting point that you could actually do something with. And there's also a limit to how much you can actually physically do in other words, the building trade, all the people you need to involve, how far they can expand capacity in the time to deliver. But I mean, if you had an extra 20 billion, which is what we've asked for, well, first off, we need to settle all the pay demands that actually are outstanding and all the pay disputes that have been provoked by ministers wanting to actually keep the pay levels below what they were in real terms in 2010. So we have to settle them. That's not a huge amount, but it's out of the 20 billion, but it's significant. Secondly, we have a major problem with hospitals falling down, lack of maintenance. We've now got a backlog bill for maintenance across hospitals in England of £11.6 billion. These are maintenance jobs that or replacement of equipment that should have been done years ago and should have been done as part of routine, but because NHS capital has been so restricted, they've not been able to do it. So I think we need to allocate 3 or 4 billion, maybe 5 billion towards starting those schemes, tackling the most urgent of those needs as quickly as we possibly can. In addition to that, you've got these hospitals, 7 hospitals, that are actually riddled with this rack concrete that's been, has caused that crisis in the schools just recently, and need rebuilding. And some of these are coming out above £1 billion to rebuild. So we actually need money to allocate to start those schemes going as soon as we can get viable designs. We need to start doing that, because some of them could actually be at the point of falling and injuring patients and staff in the process. So they are dangerous. Mental health is something that doesn't often get discussed in this context. The Royal College of Psychiatrists has calculated they need 3 billion of upfront investment to actually modernise some of our mental health units, which are terribly outdated and unsuitable for modern methods of treatment, and to invest more in the longer term also in revenue to increase staffing and bring those services up. We have horrible waiting times and delays, particularly for children, but also for adult care in mental health. But we also, in mental health, we need to start to expand NHS mental health services to make sure we're run down and eliminate the numbers being sent to private sector providers, which is extremely, it's costly, but it's also extremely inefficient, because the private sector providers have a financial interest in keeping patients as long as possible, in doing as little as possible to get them out of hospital. And what we want is them brought back into the NHS mainstream, in which their whole focus is on making them fit enough and mentally well enough to go back into the community and resume their lives in the community. So I think we need, it's a range of different things that need to be done, some of which you can do at once, some of which you need to have the resources there to do as soon as you get the plans in place. But we want that money up front so that we can actually say, this is the start, to give staff in the NHS a bit of light at the end of the tunnel they've been in since well before COVID, right the way through the COVID pandemic. Nothing ever seems to go better. Everything seems to get worse. We need to turn that corner. You need a commitment up front from a new government to say, look, we're going to do things differently. Here's the down payment. This is what we're going to do. I think that will excite people. It will win fantastic amount of support. And it can be done by a relatively small amount of additional taxation on people who can well afford it. So I think that's the argument for it.
Amazing. I did want to touch a little bit on the question of what do we have to be proud of. Obviously, we've been speaking a lot about some of the amazing innovation that the NHS model itself is to the way healthcare is delivered across the world. But there is even more that we have to be kind of proud of in what the NHS itself has contributed to the world of healthcare over the decades. But before we go there, I do want to touch a little bit on the last bit you spoke about in terms of paying staff what they've earned. Obviously, when you speak to politicians and some of these health policy experts at the Health Foundation and other places, they'll tell you, well, we're actually putting a lot more money into our NHS now than we've put in our NHS ever before. But we are seeing that productivity has stagnated. And it's almost as if, and they'll tell you, well, we need to study it and find out why that has happened. And basic common sense will tell you that if staff morale is in the gutter, and it is, we're going to see productivity suffer, right? If you might have whatever number of them you have, if morale is not high, it's going to see people leave. It's going to affect the work is affecting the mental health of those that are in the service. The question, I suppose, is beyond pay, what more do you think staff need to be given, right? We need to kind of view what they earned beyond the question of just giving them more money. Obviously, that's the most important part of it. But is there a broader package of support that staff need to be provided in order to make sure that they're getting the kind of the appreciation that we think they deserve for making the system tick?
Yeah, I mean, I don't think NHS staff in the main, I mean, a few might, but I think in the main, they don't join for the lavish pay, and they don't join to get rich. But neither do they expect that if they work year after year, increasingly under increasing pressure, and find the real value of their wages has gone down over the years, and they're actually worse off in real terms than they would have been on that pay in 2010. So I think a commitment from a government to actually restore the value of the Agenda for Change pay deal, which was negotiated with the unions and produced a whole period of very constructive working with the unions. I think that would be a major step forward. You know, it was negotiated by a new Labour government in the 2000s, early 2000s. It was actually, and it was based on evaluation of the jobs and the content of the jobs, and rewarding that. Now we have a situation now where the band 2 of Agenda for Change is in April is going to be only 10p an hour more than the minimum wage. So that's how far it's been eroded. When it was set up, band 1 was above the minimum wage. Band 1's now been effectively largely abolished. Band 2, the bottom of band 2 is now just 10p above the minimum wage. Now, our NHS staff are worth more than that. And the job evaluation in the Agenda for Change proved they were worth more than that. So we need to make sure that's attended to. But I think they, as you say, they need more. And it's just appalling some of the ways that the conditions that staff are working in. You know, night staff in particular. You know, you should have a hot meal available for night staff on their break. just improves morale, boosts energy, and just makes them feel like they're being well looked after. I think we need to just take lessons from some of the things that were put in place during the peak of the pandemic. When staff were working under the greatest pressure, various things were put in place. They had free car parking. That's been taken away, right? They had various people, all kinds of people, Michelin-starred chefs and other people delivering them meals and so on. Now you can't get a hot meal in many places over that night shift. You put that back in place. Mental health support was there. All kinds of additional flexibilities were found. And all of those were the type of thing that should be done all the time to show staff they're valued and to make staff feel that they're part of a team. Interestingly, a number of hospital trusts brought their support services back in-house after the pandemic, saying they'd learned from the value of the work that they do and they wanted them to feel part of the team. This should be just rolled out across England as these contracts come up for re-evaluation, which they do. Roll them back into the NHS, make them part of the team, show that they're valued alongside the professional staff, who of course we want to look after and make sure we keep them in the NHS. There's no point in following Wes Streeting and these other people talking about training more people, and the NHS England training more people if you're going to lose them almost as soon as they complete their courses. Doctors going overseas, staff going off to other things, that's no good at all. We need to be retaining the staff and showing them how they're valued in the NHS. And that not all of that by any means is money. And it's also a question of a zero tolerance attitude from NHS management on bullying as well, which is a big, big deal. Bullying and harassment is rife in so many hospitals up and down the country. And management continue to look bemused about the idea. There was one hospital trust I was asked to do a look at their personnel policy. They thought we've got a fantastic people policy, and halfway through it says most of the people who leave within the first year, right? So, and of course they leave, and they're almost impossible to interview about why, because they've gone because they just cheesed off with the way they're treated by management. So if you've got that and you don't have that as the number one problem, then you're wasting your time talking about the other things you're going to do as a personnel policy. That's what you need to attend. Why are people driven away within the first few months of qualifying and doing the job they trained for years to do? Why does that happen?
The job they went to because of the love they have for it. It's not a job that makes you wealthy. It's a job that you do because you care about it. Absolutely. Exactly. So we're going to finish up in, let's say, 5 minutes, but I wanted us to kind of wax a little bit lyrical about the NHS, if possible. Obviously, our NHS has kind of contributed to a great amount of medical innovations and in terms of treatment and diagnostics over the years. And I made a note about new advancements in hip replacement surgeries in the 1960s. We saw the world's first heart, lung, and liver transplant in 1987. And even up until 2021, for example, we had the recovery trials that essentially involved around 40,000 people. It was funded by the medical, I've forgotten exactly what it's called, the research funder in the country, that involved up to 40,000 people across 185 sites to find therapies for COVID-19. And these are things that the NHS is able to do because obviously we see that this is also done in the universities because profit is not as much a part of the search for kind of knowledge and development and innovation. It's just a question of how do we do better for people. And I'm wondering if you have any thoughts about kind of the history of the NHS as this amazing innovation, as you put it earlier, that continues to push the boundaries of how we provide the best healthcare to the most number of people in the most efficient manner.
Yes, well, as you say, I think it's easy to look at these various private sector people pose delivering new types of services or delivering attractive looking services with all the frills and whatever. But the core research on joint replacements and so forth was possible in the NHS because you have a whole population to deal with. And you're not selected down to a small minority of wealthier people who can afford to pay or are covered by health insurance. You're actually looking at a whole population, and that means the techniques for being able to do that with older patients as well, rather than simply younger ones who would recover quicker. So all of those techniques and new anesthetics and things that are tested out, you're able to test them out on a whole population rather than and develop expertise based on their needs. And the private sector is never going to be able to do that. And you know, that again, the fact that you were able for the first time to lift a whole burden of potential health costs from everybody. And when Nye Bevan was proposing the NHS, he addressed particularly the middle classes. He's saying because a number of those will not be eligible for any of the poverty relief or anything that some of the very poorest might be able to get. They have to pay, and you know, the shadow of bankruptcy hanging over households that need relatively minor medical treatment, but it means going into a hospital and paying. And so on. So I really do think that the idea that the NHS is a service for all. It's for the rich who have accidents, have cardiac arrests in public places or whatever it might be, and actually need emergency that way. But it's also for the very poorest to be able to access the most advanced treatment that's necessary for them that can be done within the NHS. It's the only type of system that can guarantee both of those are available. So I think, you know, we have a heck of a lot to be proud of. There are governments around the world that have modelled themselves on the NHS. In Spain, in Greece, in Greece, in Italy, in Scandinavian countries, they've got models which are very similar. The Canadian system has got broadly a tax-funded universal system, broke away from an American-style system in the 1980s and formed, and then it's got its difficulties because it's of its history and the way it's evolved. But again, in Canada, you've got universal healthcare for 30-odd million Canadians. South of the border, you know, they've got a complete mess on their hands in which so many are excluded from full access to healthcare. So I think the NHS is a model that has actually continued to deliver and show what can be done. And be something we can be extremely proud of. But of course, we want the party that takes over of this next election to be not just proud of it, but show how they respect it by doing something to actually rescue it. And we need to pile the pressure on to make sure that happens. So I think now they probably will get elected. The question now is how we fight them to make sure they do the right thing.
Absolutely. And I did just want to say, obviously, you pointed to a moment ago, the contrast between Canada and the US. And even in the United States, the two most popular healthcare provisions in the country are what they call the VA, the Veterans Administration, and Medicare, the care for older people, both of which operate pretty much like the NHS, all right?
Yes, and extremely low overheads, which is very interesting. Extremely low overheads, particularly in Medicare, where it's for care of the older people, and basically their overheads are down to single figures of percentages, like 8%. That sticks in my mind. Whereas the private sector is running at 30-40% overhead costs. And absolutely, crippling. Wow. Just imagine the NHS running with 30% overhead costs. We'd hardly get anybody treated at all.
Absolutely. Well, John, thank you so much. I saw a comment from somebody earlier that said something essentially great session, and I was going to say that is not because of me, it's because of John. So thank you so much, John, for an incredibly insightful, yes, Delma says excellent session, many thanks. I think Delma is pretty much talking to you. Paula says, well done, well said, John. NHS staff need to be supported by decent terms, conditions, and pay, as well as their services being resourced sufficiently to allow optimal patient care. Staff retention is key. Paula is absolutely correct. And as John said earlier, there's no point in training new staff if they're going to leave a year after coming to into the profession. So we need to keep those that we have. Hillary buttresses what we've just been saying about some people are excluded from primary health insurance in the States if they're considered bad risk in financial terms. And of course, they used to be able to prevent people who had pre-existing conditions getting health insurance. Obamacare changed that, but it still does not make it that easier for people to deal with. If you, for example, have a bad lung, you can't get health insurance, or your health insurance premium is going to be too high. Those are things that we don't have to worry about here. And finally, I'm going to just read one more. Mark Jones says the top class treatment is, paradoxically, for the private hospital consultants, directors, and shareholders, not so much for patients. Thank you so much, everyone, for being here. And thank you very much, John, for a really, really insightful conversation. Thank you very much, Matthew, for stepping into the bridge when my electricity decided to give way. It has been a really, really eye-opening conversation, and I hope that everyone is going to be able to join us on Thursday at 6 p.m. for the launch rally of our pledge for the NHS campaign. We want to invite every candidate to take the pledge for the campaign. The campaign has a support of a number of celebrities. We don't want to say who they are yet because we want it to be news on Thursday. But please do join. We have gotten the support of tens of local campaign groups across the country. And the goal of that is to bring together as many people as possible so that those people can then get the word to the people they speak to, the people they're connected with, and as much of us as possible put pressure on candidates so that they pledge to us that if elected, they will be fighting for our NHS, not just doing whatever their party says they should do. Thank you so much, everyone. Thank you, John, for joining us. And I hope everyone who is viewing this is going to click the like button if you can. Please do click that like button right now. It helps get this to everybody. So click the like button, share the link with your friends and family, and I'll see you on Thursday. Thank you so much, and goodbye.